Hello everybody, I am Dr. Sandeep. I am a senior consultant in the Department of Radiation Oncology at Apollo Hospitals, Navi, Mumbai. Today I will be speaking on the recent advancements in the field of radiation oncology. As you all know that radiation along with surgery and chemotherapy form the three major established pillars of cancer treatment. And it has been established that almost 65 to 70% of patients would require radiation therapy in their lifetime, either for cancer control, cure, or for palliation of their cancer-related symptoms. Now, there have been a significant improvement in the planning and delivery of radiotherapy technologies over the last couple of decades. We have moved from conventional radiotherapy, where we used to give simple rectangular fields, to the current concept of three-dimensional conformal radiotherapy, otherwise known as 3D CRT, or intensity modulated radiation therapy known as IMRT. Now, to give you a brief outline of how we do a radiotherapy planning, what we really do is, when a patient comes to us after the consultation is over, we ask for a radiation planning CT scan, plus minus an MRI, or sometimes even a PET scan. That forms the baseline scanning technique. Now, once the scans are done, all the images are pulled into our planning system, and then we sit down on the system and we mark out the tumor which is visible on the scans. So the first step is known as marking out the gross tumor volume, which is otherwise known as GTV. Then we have to account for all the subclinical or the microscopic disease. So the gross tumor volume with the microscopic and subclinical disease is drawn, which we term as clinical target volume, or CTV. And then there is a margin given to the CTV to account for all the random and the systematic movements or the errors and the physiological changes in the organs. So this is called the planning target volume, otherwise known as PTV. Now, ultimately, radiotherapy is planned or delivered to this PTV. So this is all about the target. So along with the target, we mark out all the surrounding critical normal structures of the tumor, and they are known as organs at risk, or OAR. And then the actual planning process starts. So the basic idea of any radiotherapy planning is the target volume, that is the PTV, should receive the prescribed dose of radiation, and all the surrounding critical normal structures, or OAR, should receive as minimal dose as possible. Because it is understandable that higher the dose to the OARs, or the surrounding critical normal structures, higher will be the side effects during the time of radiation, which we call acute side effects, or in the long run, which are known as late side effects. So the basic idea of the technological advancement was to optimize this process of delivering the prescribed dose of radiation, concentrated into the PTV, and delivering as minimal dose to the surrounding critical normal structures. In the meantime, we got robust data based on research work that if we could increase the dose to the tumor, known as dose escalation, there were higher chances of control or cure achieved. So the first computerized planning technique which came into effect was known as three-dimensional conformal radiotherapy, otherwise known as 3D CRT. It's in use for many years now. The biggest problem with the limitation of the system was very high dose to the surrounding critical normal structures. So the side effects were very high. So came in the technique called intensity modulated radiation therapy, otherwise known as IMRT. It created a paradigm shift in the entire radiation planning and delivery process. So what happened in IMRT is that the modern computers divided the entire beam of radiation therapy into multiple small beamlets, and the fluence or the beam modulation was achieved and it gave rise to basically a dose inhomogeneity within the target and a sub-dose follow-up at the periphery. So as we all know that tumors are never spherical, they are highly irregular structures. So IMRT basically optimized giving radiation to irregular structures and created concavities in the radiation planning or treatment volume. So what we achieved with IMRT was full dose to the target volume with significantly reduced dose to the surrounding critical normal structures. So the side effects, both acute and late, came down significantly, and that gave us the option to escalate or increase the dose to the target volume. So at that point of time, IMRT became the standard of care. But science is an evolving process. We come across new problems and we try to solve all those problems. So what we realize gradually is that IMRT is just like my computer screen, where there is no movements, which is static, and this is a theoretical aspect. On the other hand, the human body is a practical problem. No organ in the body is a fixed organ. There are internal organ motions, the physiological changes in the target volume as well as the organs at risk, as well as daily setup uncertainty or errors during the time of treatment. So as I just said, the human body was a practical problem. So we needed a bridge between this theoretical and the practical problems. So came in the concept of image-guided radiation therapy, otherwise known as IGRT, otherwise known as image-guided IMRT. The planning technique stayed IMRT. So image guidance was added as another tool, specialized tool, to improve the delivery of radiation therapy. So the modern radiation therapy machines incorporated a CT scanner within the machine. So these are basically called as cone beam CT scan. So on a daily basis, before the patient is being treated, once the patient is stabilized on the treatment couch, just before the treatment is being delivered, the machine takes a rotation and a CT scan is obtained. Now this CT scan on a daily basis is superimposed on the CT scan, planning CT scan, which we had taken on day 1, where we have marked all the surrounding critical normal structures and the target volume with great details. And definitely they didn't match. So the image guided computer algorithm matched it organ to organ, target to target, and then we did a manual verification, and once we are satisfied, the radiation beam was fired. So the beauty or the advantages of the IGRT system was, we didn't treat the tumor blindly. We took the help of a CT scanner to identify the tumor, position it, and then direct my radiation therapy. So the accuracy or the precision improved significantly. We could manage with a lesser margin for the PTV. So IGRT basically helped us to target the therapy or radiation to the PTV or my target volume, along with sparing of the surrounding critical normal structures. So it helped us to deliver a higher dose called dose escalation, and as well as helped us in delivering a very high dose of radiation therapy known as hypofractionation, and thereby shortening the overall treatment time. Now, radiation machine has got a head. Unlike a CT scanner, which is a gantry, the radiation machine has got a head. Now, based on the computerized planning, the machine or the head stopped at various positions, somewhere less than 10 areas, and used to deliver the radiation therapy. So the cumulative radiation timing was somewhere around 10 to 12 minutes. Next came the concept of something called as volumetric modulated art therapy, wherein the radiation treatment was delivered in a dynamic fashion while the gantry was rotating all around the patient. So it is a novel technique of delivering radiation therapy, and it was suitable for treating tumors which were close to very sensitive or critical organs, as well as tumors which are likely to move during the treatment or in between treatments. So, volumetric modulated arc therapy, otherwise known as VMAT, the beauty of it was the precision and the rapidity with which it delivered radiation therapy. So the entire treatment time came down to almost 2 to 2.5 minutes. So when we could deliver treatment in such a fast manner, the accuracy improved. We could take into account the errors which used to happen during a particular fraction, and definitely it was much more convenient for the patient, and patient compliance also increased. With the data from the image guided technique, what we learned is that the planning which is done on day 1 might not be suitable for the treatment for the rest of the duration of radiation therapy. Now, radiation therapy is a long drawn process, the conventional radiation therapy, where treatment happens daily, 5 days a week, that is Monday through Friday, and the treatment continues for around 5 to 7 weeks duration, depending on the total dose of radiation we are delivering. So, what IGRT told us was that there can be tumor shrinkage in between the tumor, there can be weight loss, there can be physiological changes in the target volume as well as organs at risk, and organ mobility. So, a plan which has been created on day 1 cannot be suitable for treatment for the rest of the duration. So, came in the concept of adaptive radiotherapy or dose painting, which is a kind of tailored treatment, tailored according to the situation. So, it's a closed loop process where we get measurements from the imaging we do daily and then tailor our treatment. So, it can be tailored depending on a weekly assessment, or it can be a daily treatment, changes. So, the simple process is when we do an offline correction, and the more complicated process is known as the plan of the day, where we create multiple plans and the best suitable plan for the day is taken up from the library for the treatment. The next challenge came to us when we start treating tumors from the chest as well as the abdomen, that is respiratory movements. So it was a huge challenge, and we required some kind of real-time position management system to counteract that. So there are multiple devices to do that. We used to put radio frequency markers or even radio opaque markers inside the tumor. These are called fiducial markers, and which were picked up by external devices to mark or monitor the tumor movement. Then we have respiratory gating system. As the word gating means that we open the gate of our house to allow somebody to come in, and when we don't want somebody to come in, we close the gate. So came in the technique of respiratory gating, where we could treat treatments even in free breathing or sometimes in breath hold techniques. So what happened was, came in the concept or the technique of 4-dimensional CT scan. So what used to happen there is, all the CT scan acquired during the time of planning were divided into 10 different phases of the breathing cycle, and all the images were stacked respectively into those cycles. Now the radiation oncologist along with the medical physicists used to identify the phase where there was least movement of the tumor, identify those phases, and the actual treatment used to happen during that particular phase of breathing. The other way of treating a tumor is through breath hold techniques. As for example, we treat left-sided breast cancer in deep inspiration breath hold technique, otherwise known as DIBH. Sometimes we treat liver tumors in end expiratory breath hold techniques. Now came in a paradigm shift when research work told us that if we can deliver a very high dose of radiation per fraction, we could reduce the total number of fractions. So came in the concept of stereotactic radiotherapy. This is a specialized technique of external beam radiation therapy, wherein a very, very high biologically effective dose is delivered in a three-dimensional stereotactic manner to a target in the body, delivered in a very precise manner, in an accurate manner, so that the entire dose is concentrated to the target volume with very minimal dose going to the surrounding critical normal structures, usually delivered through some kind of image guidance over a few sittings of radiation therapy. So, a tumor treated in this fashion in the brain or in the spinal cord is known as stereotactic radiosurgery. Though the name surgery is there in it, it is not at all a surgery. We rather use the radiation as a knife. So it is known as a kind of, it's a non-invasive procedure, bloodless procedure, and we are using radiation therapy for it. Now, stereotactic radiosurgery is used for various benign, malignant as well as physiological conditions of the brain. There can be three systems with which we can perform SRS or stereotactic radiosurgery. When a linear accelerator is modified, this is known as X-knife. Then we have gamma knife, where we use gamma rays to treat a cancer or a tumor, and we have a robot mounted device known as cyber knife. Now, when the same kind of treatment is done for a tumor which is situated outside the central nervous system, it is known as stereotactic body radiation therapy, SBRT, also known as stereotactic ablative radiotherapy, SABR. So the ASTRO defines SBRT as a total number of radiation less than equal to 5 sittings. On the other hand, in stereotactic radiosurgery, the treatment usually happens in a single fractions or sometimes in 3 fractions. Now, you can find my talk on stereotactic body radiotherapy in the same platform, so you can refer to that. I won't speak much on SBRT. The indications are gradually increasing. We can treat lung cancer, liver cancer, tumors in the prostate, in the pancreas, lymph nodes, even in the head and neck. So the evidence is gradually increasing, and it's over-widening. Coming to the last but not the least is particle therapy. So particle therapy is an emerging form of radiation therapy. High energy charged particles have a distinct advantage physically and radiobiologically over normal radiation therapy. So what happens in proton is that the charged particles, they don't deposit their energy in the initial part of the travel and suddenly deposit their entire charge in a small area or volume which is known as Bragg peak, depending on their energy. So this can be utilized with their advantages of dose homogeneity and lesser dose to the surrounding critical normal structures. So proton and carbon are the established form of therapy. There are other particles also coming into the picture, and throughout the world, lot of centers with big accelerators are being prepared. The major disadvantage of proton, or the debate regarding proton, is the cost effectiveness of the treatment, because it takes a huge cost to build a proton therapy or a carbon ion therapy center. So the clinical benefit needs to be looked into that. As of now, there are multiple indications of treating with proton, as for example, any kind of pediatric tumors, tumors which are in the brain close to critical structures, tumors very close to the spinal cord, and in case of treating the prostate cancer, giving radiation for the second time. Again, the horizon is increasing, the indications for a proton are also increasing. Carbon ion can be used for treating cancers which are highly radio resistant because they have distinct radiobiological advantages over proton and photons. Thank you.